Thank you. Hello, everyone. I am Roxy Logan. I have multiple sclerosis. I've been in Second Life for 20 years. I am a fine arts student in the UK. I'm introducing Dr. Mihir Gupta. He's Assistant Professor of Neurosurgery at Yale. I am also introducing Dr. Renato Polimanti, who is the Assistant Professor of Psychiatry, Biometrics, Informatics and Data Science, and Chronic Disease Etymology at Yale. We at the VIA would like to remind guests to please refrain from talking on their microphones, and please keep your questions to the end of this presentation. Thank you.
Thank you for the introduction. I'm Mihir Gupta. It's nice to meet all of you. And I'm here with my colleague, Dr. Polimanti. We'll be discussing a study that we've recently published about the relationship between psychiatric disorders, chronic low back pain, and spinal degenerative disease. Is the next slide showing up? The disclosures slide. Just make sure I'm okay, good. I have no disclosures. Here's Dr. Polimanti's disclosure from Carver Publishers. So, as a neurosurgeon and a spine surgeon, most of what I do relates to back pain in some form or another. And most of that comes from the type of back pain that almost everyone will experience at some point in their life. Most of those episodes are limited to a few weeks or less, but the focus of this study, and really a major public health problem worldwide, is what we call chronic low back pain. And that lasts for at least 12 weeks or about 3 months, just the way that we define it. Now, as surgeons in particular, we're often asked to identify if there are particular structures in the spine that cause low back pain in each person. And as I'm showing on this slide, there are many structures that can do so. Most of them are in the spine itself: joints, discs, bones, and nerves, and muscles. There are also many structures outside the spine that can cause pain that mimics pain that's coming from these structures. Those are things like the hips or the sacroiliac joints, as two examples, and in some cases even structures in the abdomen that can cause back pain. But as we've learned over the years, this is just the tip of the iceberg in terms of causes of back pain and really pain in general. We now have what's called the biopsychosocial model of pain. The biological causes, things that we might address, are just one component of that. The other factors, which are as important, if not more important, are psychological and social or socioeconomic factors. All of these can cause pain or worsen it, and really profoundly influence treatment outcomes. Now, the focus of this study is the intersection of low back pain and different psychiatric conditions. And this is, a complex set of relationships. So just to touch on some of those and what we've learned really from the broader scientific and clinical community. For example, We've historically thought that psychiatric conditions can increase pain sensitivity, but more recently we're understanding that that may be more complex than we originally gave it credit for. And it's not just a one directional or simple relationship. Now, among people with degenerative disease in their spine, so wear and tear, you could say, on their discs, their bones, their joints, and so on, psychiatric conditions, especially things like depression and anxiety, can often correlate with worse pain outcomes. And even when we give the same treatments, they can lead to less satisfactory treatment outcomes. So more difficulty treating these conditions. And so what we speculated, what we hypothesized when starting this study, and the reason that Dr. Polimanti and I collaborated on this, bringing both of our expertise, is that we asked, is there something else that could be making it more likely to develop both chronic low back pain and psychiatric conditions in the first place? Is this more than just a coincidence that these two are both happening and that they both have some relationship to each other? And so some of the questions that we asked are, first of all, what's the relationship, just on a numbers basis, between psychiatric conditions, degenerative disease of the spine, and chronic low back pain? We then dug a little deeper to ask what might be the reasons, the mechanisms for those relationships. And finally, how can we use that information to come up with better personalized treatments? And so I'll turn it over to Dr. Polimanti at this point.
My microphone is now working. I think you should hear me now. I see the green thingy on my head that is moving. Yeah, okay, great. Sorry, like is my Second Life is freezing sometimes. Hopefully while I'm speaking it's not going to happen again. Okay, thank you so much for this invitation again, and Dr. Gupta for the very nice introduction. So the part that I'm going to talk about is about the analytic design of our study, how we integrated different type of data, some observational data, which are the actual outcome that we assessed, and genetic data. So first of all, I would like to talk a little bit about the difference between causation and correlation. So our hypothesis is that psychiatric disorders or the genetic predisposition to psychiatric disorders may be associated with an increased risk of chronic low back pain and spinal degenerative disease. However, we cannot be sure of that because there may be dynamics that create a correlation between these two type of conditions. Next slide. So because again, it's an important difference between causation and correlation. So here is a very easy and I think timely example. We just entered summer, and so like when there is hot weather and strong sun can lead people to have an increased risk of sunburn if they don't use sunscreen protection. So there is a causality relationship. And at the same time, the hot weather can increase the ice cream sales. And so if we don't look to, and we don't know about the cause of these two phenomena, we may observe a correlation between sunburn and ice cream sale, but this correlation has nothing to do with causation. And so understanding if an association like the one between chronic low back pain and psychiatric disorder is a correlation or causation can have important clinical implications. Next slide. I'm not sure if...
I think we're showing the next slide with the...
Okay, yes, because again, I have this second life issue. So if you are seeing the second slide, I will talk about that immediately. What we can do to distinguish between causation and correlation, we can do different type of studies and use different type of data to analyze that. And so like with different type of design, we can confirm a correlation, which is an important first step. Second, we can do an observational causal analysis where we are actually making some assumptions about the type of study that we are doing. And then the final step is to do an actual experiment. In this case, a randomized experiment where we test the causal mechanism linking two phenomena. Next slide. And so like here are the different type of study design. So when we have a cohort, a case control study, or an ecological sample, we are simply observing data, and due to the nature of the cohorts and samples that we are using, we have very limited ability to establish strong evidence of causality. Then we can do like actual intervention. We can do an randomized control trial. The abbreviation is RCT. And this is actually an intervention where we assign people to different intervention and make like an inference about the causality. And of course, if we have multiple randomized control trials, we can combine this information and derive stronger evidence about causality. Of course, like the stronger the evidence and the design that we are using to derive that, more expensive it is and more difficult it is. So like people recently, because we have more genetic data, use like a Mendelian randomization approach. Next slide. I'm assuming that we are on the next slide because unfortunately I cannot see that on my screen. And so like we can use genetic information to derive and assess the relationship between an exposure, which is going to be our risk factor, and an outcome. So because we are talking about genetics, and genetics is things that is known among people, but again, I want to be sure that we are all on the same page. And so next slide, unfortunately, I'm still on the causal evidence slide. Now you should be able to see two different mechanisms underlying genetic predisposition to human traits and disease. In one mechanism, we have a rare condition that is linked to monogenic inheritance. And so in this condition, we have that a single mutation is associated as a causal effect on the disease of interest. And following this mutation, in this case, we have an affected father and an affected mother. The affected father is a carrier of this mutation. And if this mutation is transmitted to their children, the children that will have the mutation will have the disease. Because again, mostly this monogenic inheritance is linked to rare disease. But most of the conditions that we see among people are not linked to a monogenic inheritance. They are linked to a polygenic inheritance, including psychiatric disorders and pain-related conditions. In this case, we don't have a single mutation that is causing our phenotype of interest, but there are many genetic variants in our genome that each of them contribute a little bit to increase or reduce the risk of the disease that we are studying. And so on the bottom right of the plot, you can see this distribution. On the left hand, you can see individuals that have very few of these variants that increase the risk, and they are going to be very few. Then you have in the middle of this distribution that most of the people will have a certain amount of variance, and then on the right tail of the distribution, we have a group of people in red. There are the people that have high risk, and these are going to be the people that have a high genetic risk and are more likely to develop the disease. Next slide. And so like this polygenic inheritance is basically partially explain the family risk that we observe for certain conditions, including psychiatric disorders. And so here we have the relationship between schizophrenia and familial risk. So if we have identical twins, so two people that have exactly the same genome, we have a 48% of the risk. So if one of the twin have schizophrenia, the other has like a 48% of probability to develop schizophrenia as well. Then we have fraternal twins. The fraternal twins are twins, but they share only 50% of their genome. And we can see that since they share only part of their genetic profile, we have a reduced risk, which is 17%. And then going to more distant family relationship, this risk reduce. And this is due to the fact that the risk is not due to a single mutation, but is due to a large amount of genetic variants, probably thousands of variants that people inherit to develop this risk. Next slide. And here we can see like more details about the difference between rare mutation with very large effect, in some cases linked to monogenic inheritance, and common variants. And so here we have this plot where on the x-axis we have the frequency. So on the left side we have variants that have very low frequency, so they are very rare, only very few people have them, and they are associated with a very high risk of schizophrenia. But again, like they have a high risk, but they are present only in very few individuals. On the right side, we can see a lot of like on the bottom right corner, a lot of blue dots. And these blue dots are hundreds of variants that we now know. And these variants have very small effect size. So each variant by themselves is not associated with an increased risk of schizophrenia. But altogether, if a person has too many of these variants, can develop schizophrenia because of this high genetic burden. Next slide. And so like, which are more important? Again, from a biological point of view, all are important because all are giving us information about why certain people are predisposed to the disease. But if we account for how much they can explain of this predisposition, here we have another example which is related to autism spectrum disorder. And so we have three different lines. And so on the first line, you can see that there are a lot of different variants, and these are very rare. And sometimes have strong effect with respect to the risk of autism spectrum disorder. But if we combine all of them together, they explain less than 10% of the cases. Most of the cases of autism spectrum disorder that we see are not due to these rare variants, but they are due to the contribution of many variants that people inherit. Next slide. And so how we can model this polygenic architecture, meaning that there are many genes that we have to account. We can develop a polygenic score. A polygenic score is basically we calculate for each individual how many variants they have that predispose to increased risk or reduced risk. And so here we have two groups. On the left side, we have people without the disease, and they have a lot of these blue variants. And these blue variants reduce the risk, and so predispose them to be controls. On the other side, on the right side, we have people with the disease. And so a lot of these people have variants that increase the risk, the red one. And next slide. And so if we combine for each individual their risk, which is due to these many variants that they have in their genome, we have the distribution that we saw before. On one side, people with decreased risk, then in the middle, people with average risk, and then people with increased risk. Next slide. And so what we can do with this polygenic score? With this polygenic score, we can conduct a Mendelian randomization that, as I mentioned before, is an approach that has some similarity with a randomized control trial. A randomized control trial is the gold standard to perform causal inference analysis. But as I mentioned, is expensive, and in some cases is not possible to conduct a randomized control trial, because, for example, if we want to assess the impact of psychiatric disorders on chronic low back pain, we cannot assign some people to having psychiatric disorder and other people not having. So in this case, it's not feasible. So what we can do, we can stratify our sample based on their genetic predisposition. Next slide. And so, while in a randomized control trial, we usually use a medication. So in this case, the example that we are having is that we want to test if CRP, C-reactive protein, which is an inflammatory biomarker, is reducing the risk of systolic blood pressure, SBP in this case, the abbreviation. And so this would be the standard randomized control trial. You randomize treatment between treated and a placebo group, and you assess long-term the difference. But again, we can do a similar study using genetic information. So instead of having a medication, we can distinguish our patients basing on those that have a high genetic risk of having a low C-reactive protein, so low inflammation, and people that don't have this predisposition. Next slide. And so in our study, we decided to use both observational data, actually assessing people that have psychiatric disorders, and testing them between three groups. One group is people that have both chronic low back pain and also a diagnosis of spinal degenerative disease, people that report only chronic low back pain, and people that report only spinal degenerative disease. And so we wanted to understand if there were differences. But in addition to use psychiatric diagnosis, we wanted also to do a genetic study, because we wanted to have more evidence about possible causal relationship, and also because we wanted to understand if there were some molecular target that could be used to identify drugs to treat this condition together. Next slide. And so to do that, we leverage two different cohorts. One is the UK Biobank, and the other is the All of Us research program. Next slide. So the UK Biobank in human genetic research is a very famous cohort. This was recruited in the early 2000s and reached a total sample size of 500,000 participants that were recruited across different sites in the UK. And for these participants, we have information from questionnaire, from surveys, from their electronic health records, genomic information were generated, metabolomic information, proteomic information, imaging data. And so it's a very well-assessed cohort. Next slide. But of course, we also wanted to use an additional cohort, and this is a more recent cohort. This is was designed in the US and is actually still recruiting participants. The goal is to reach more than 1 million participants that are going to actually reflect the diversity of the US population. So currently for these participants, we have surveys, questionnaire, and electronic health records together with genetics. So other kind of like molecular data and imaging data are in the process. So here you can see that the sample size of participants enrolled is more than 870,000. But unfortunately, at the time of our study, the sample size with complete genetic and phenotypic data was much limited. Next slide. I'm assuming we have moved to our next slide. And so in these two tables, we can see the differences in characteristics between these two cohorts. And so let's start with the table on the left. So as I mentioned, the UK Biobank has more than 500,000 participants, but of course, we needed to filter out some participants that didn't have the information that we needed, didn't have complete genetic data. And so like our total sample size for the UK Biobank was a little more than 400,000 participants. These sample size look very large, but for genetic studies, like actually like are again, they are large, but they are massive. Like for more recent genetic study, we can reach more than 1 million participants. So with respect to the all of us, as I mentioned, like there are more than 800,000 participants, but in our study, because of the data that we needed, we got a little bit more of 150,000. And so if we compare these two, we can see that in the All of Us research program, there are more females. The age is a little bit lower than the one reported in the UK Biobank. The BMI, the body mass index, is higher, highlighting possible like increased overweight issues in the US population. And then if we look to the ancestry, which is the ancestral background of this population that we assessed using genetic information, we can see that while the UK Biobank reflects the diversity of the UK population, which is rather limited, most of the individuals have a genetically inferred European descent. In the All of Us research program, we can see that is more diverse, and so which is partially reflecting the diversity of the US population. And then let's move on the table on the right. So in the table on the right, we can see the prevalence of different psychiatric disorders. Here we reported the abbreviation, but I can explain a little bit to you. So AUD is alcohol use disorder. So you can see that the prevalence is a little bit higher in the All of Us, and then we have anxiety, attention deficit hyperactivity disorder, ADHD, BD will be bipolar disorder, CUD is cannabis use disorder, then we have depression, then we have opioid use disorder, post-traumatic stress disorder, and schizophrenia. And then we have, with respect to our outcomes of different 4 groups. One is people that report both chronic low back pain and spinal degenerative disease, people that report only chronic low back pain, and people that report only spinal degenerative disease. And of course, we have a control group. And so you can see that, for example, like the prevalence of these conditions is slightly more higher in the All of Us, except for people that report spinal degenerative disease, which is higher in the UK Biobank. And so these could be differences between diagnostic criteria between the US and the UK. And so like some of the differences that we'll see in our results may be driven by the different assessment, the different background, clinical background that these 2 courses were derived from. Next slide. And so the first analysis that we did is the observational analysis. And so here we actually tested people that have a psychiatric disorder with respect to the 3 outcomes group that I just explained. And so we can see that the results are pretty much consistent between the UK Biobank and the All of Us. And so like as expected, we see an increased risk of the 3 outcomes with respect to AUD, anxiety, depression, and post-traumatic stress disorder. However, post-traumatic stress disorder, we see an inverse relationship in the All of Us, AOU in the plot, the plot on the right, where PTSD actually is reduced. People with PTSD have actually a reduced risk of spinal degenerative disease, which is not present in the UK Biobank. And then for the final one, we have a difference between the two, because this observational analysis was limited to people that actually we had in each cohort more than 100 cases. So we have more than 100 cases for the schizophrenia, and here we can see, again, a negative relationship. While for the All of Us research program, we had information about bipolar disorder, and in this case was more in line with what observed for the other psychiatric disorder. Next slide. And so, after this first step, we decided to actually test the genetic predisposition. And in this case, we didn't need actually people with the diagnosis, so we were able to test all conditions, also the one that we had a small number of cases. And so, first of all, there is a major difference between the UK Biobank and the All of Us research program. The main reason is the All of Us research program is smaller in sample size, and this means that we have a reduced statistical power, and so we can see that the effect where we see a strong difference between people with high and low genetic risk are much smaller. And so in this case, we are using the UK Biobank as our primary sample. And so we can see here that there are also stronger differences across the different outcomes. So for example, for anxiety, depression, also alcohol use disorder, the genetic risk was more strongly associated with people that had both chronic low back pain and spinal degenerative disease. And again, this trend was also present in the All of Us, because the blue line, which is the blue sign, which is the one that we have for the comorbidity between the two, is the one that usually shows the larger effect. And so this may be due to the fact that the genetic risk is associated with people that have more severe case that lead to the comorbidity between these two conditions. But however, the other aspect that we wanted to test here is these genetic effects, because of course, psychiatric disorder have a partial genetic overlap in their predisposition, so we wanted to understand better if these genetic differences were due to the same genetic effects or distinct genetic effects. Next slide. And I guess you move to the next slide. Yes. So, and here we did a multivariable polygenic risk score analysis. So in this case, we are accounting for the genetic overlap between these conditions. And so in this case, we can see that the stronger effect are actually due to a smaller number of psychiatric disorder. And in particular, depression showed the largest effect. And then we also had post-traumatic stress disorder, anxiety, ADHD, and anxiety, ADHD, and alcohol use disorder. And then at the bottom of the plot, we actually are seeing an inverse relationship between schizophrenia and this, especially the comorbid chronic low back pain and spinal degenerative disease. And this is in line with the observational study. If you remember in few slides before, I showed that schizophrenia has this inverse relationship, and we will talk more about it later. But again, these are still not strong evidence of causality. And so, because again, we simply did a polygenic risk score analysis testing the association with these three different outcomes. And next slide. And so, in the next slide, we can see the results from the Mendelian randomization analysis. Unfortunately, as you can see for the All of Us research program, we still don't have a lot of power to perform this analysis. Instead, in the UK Biobank, we have a large number of patients, and so we were able to test more accurately the effect underlying this association that we observed. And so in the Mendelian randomization analysis, we use both genetic and observational data, integrating both, and actually testing possible causal effect that may link the genetic predisposition to certain psychiatric disorders to chronic low back pain, spinal degenerative disease, and their comorbidity. In this case, we saw an interesting trend. For anxiety, depression, and post-traumatic stress disorder, the actual, in the UK Biobank, so the plot on the left, the spinal degenerative disease only group showed the strongest association, which is not present in the analysis that we did before. And so this may mean that the genetic predisposition to these psychiatric disorders have a stronger effect to the specific outcome. And so instead, for the other psychiatric condition, we saw that there were causal effects, but these causal effects were more similar across these three different groups. So this means that the effect that we are observing, the comorbidity we are observing between psychiatric disorders, chronic low back pain, and spinal degenerative disease have some underlying causal relationship. And there are differences that may do to this condition that lead to different patterns of comorbidities. But then we wanted to do even more. We wanted to understand if this genetic mechanism may lead to possible drugs that we may test in the future. Next slide. And so what we did next is a genetically informed drug repurposing analysis. What's that? So to develop a drug from scratch is a very expensive and timely process, because you need to identify the molecular mechanism, identify which drug affect that molecular mechanism, and then you have the experiments to prove that there is an effect there, and then you do it on cellular models, animal models, and then there is a process that you go through. But then the other thing that we can do is to use existing drug and understand if these existing drugs that we know that are already safe for humans and are being used for other conditions may be useful also for other negative health outcomes. And so how we can do that? We can do that also through genetic information. And so through genetic information, we can understand which are the mechanisms that are used by these drugs and understand if they can be repurposed for a different condition. And so this is what we did in our study. We try to understand if these polygenic relationship that we observed were somehow good targets for existing drugs and molecular compound. Next slide. And I think you are on the next slide now. So here we have a table with molecular compounds that we found having convergence evidence from both UK Biobank and the All of Us research program. And so in this analysis, we identified, specifically in this case, the convergence was observed with respect to depression. So the polygenic risk of depression affecting chronic low back pain and spinal degenerative disease. And so here are different compounds that we identified, and this includes compounds that have affect neurotransmission, reduce inflammation, can modulate the parasympathetic nervous systems. And so in this case, there may be this could be the mechanism that could help to develop new therapeutics that may be specific to treat the comorbidity between psychiatric disorders and chronic low back pain and spinal degenerative disease. Next slide. But then, like, if we focus only on the UK Biobank, in addition to depression, we can find evidence also for other psychiatric disorder. In particular, here we have schizophrenia and alcohol use disorder. In some cases, the same compound, for example, vorinostat, which is an anti-inflammatory anti-inflammatory compound, we see a consistency between schizophrenia and depression. We also like that some antipsychotic medication may have like some dynamics that may contribute to treat also chronic low back pain and spinal degenerative disease. Next slide. And so I think that's on you, Dr. Gupta.
Thanks, Dr. Polimanti. That was terrific. And as you can see, this was a very rigorous and large-scale investigation of our original question, which is to ask if there are shared pathways that are likely to be affecting this relationship between low back pain, wear and tear on the spine, and psychiatric conditions. And some of the interesting findings that are pretty new in this study, one of which is that the immune system and inflammation, you could think of this like an accelerator and a brake, that the balance between how active or inactive that those immune processes are affect every process in our body, head to toe. And that's also something we found in this study that could be at the intersection of all three of these things. Another is that the processes of how we develop, really from before we're born and in early life onwards, how our bones, joints, and even neurons develop and generate, could also be implicated. And that led to, as Dr. Polimanti highlighted, this possibility that existing medications that target those pathways could be possible personalized treatments in the future, depending on what one's clinical profile of back pain and psychiatric conditions are. I do want to emphasize, though, that this study does not advocate for any specific medications. It does not provide clinical validation of those, but this is what we would call hypothesis generating work, in that it gives us an idea of which path to follow and maybe opens up some new directions, but a lot of work is still to be done. Now, I also want to highlight, as Dr. Polimanti was saying, the relationship between chronic low back pain and schizophrenia that we found kind of goes the other way compared to conditions such as depression and anxiety. And right now, we can only speculate as to why there are different directions of those relationships. In schizophrenia, for example, it could be that the way that pain is perceived has been altered as a result of the condition. It could be relating to how it's expressed by individuals who are going through it and what they're reporting in their clinical encounters. And it could also be in terms of how we as medical professionals are interpreting or documenting those experiences from different patients. And that leads to some of the limitations of a study like this. We've seen some of the strengths, that we have very large sample size and that this was all existing data that didn't require any patients to be exposed to the risk of a randomized trial in order to collect and analyze this information. This was just existing data from patients in multiple countries in very large numbers with a lot of genetic and clinical information, which is very unique. But the limitations are as follows. One is that we still don't know how chronic low back pain and psychiatric and spinal degenerative disease may affect the outcomes of psychiatric conditions. We've only sort of studied the other side of that question in this particular work. And also, in spite of our large numbers, populations that are minorities racially, ethnically, and otherwise just have, there's a lot of work to be done to better understand how their experiences may be different, and it's important not to generalize findings from one group to others. There's also some limitations in terms of these databases. One is that, as Dr. Polimanti said, between two different countries, the United States and England, for example, there's differences in how things are recorded and coded. And the sort of standard medical language we use, administrative language, is a little different between the two. That's sort of just the tip of the iceberg. The other issues are that, especially for the spine, in clinical practice, we rely on X-rays and MRIs and CAT scans, imaging, in other words, to also understand these conditions and understand how two people may be different, even if their symptoms are the same. And those particular images are not available in databases such as these. Only the diagnoses and the genetic information are. And so that's very important for the next generation of studies, that they should incorporate that information, building on what we found here. And also, this study was really limited to chronic low back pain. It's important not to generalize or assume that what we found is true in other chronic pain conditions. And so really the future directions that I think this work sort of opens up are that, we now have the opportunity and the directions to explore in multi-center studies, meaning multiple different hospitals and institutions, incorporating imaging and medical records. We should also look at populations of different diverse ancestry. And in terms of the medications, the drugs that we uncovered in this study that may have beneficial effects, it's important to do retrospective studies, meaning looking at existing data, and also to very carefully do prospective studies in the future. And so I'm very grateful to Dr. Polimanti and all of the collaborators that we all worked together on this study. It's published in the journal Biological Psychiatry Global Open Science. I think we'll have the link to that for anyone who would like to look at the complete published work. I especially want to highlight Dr. Dan Chu, who spearheaded this work and the analysis for her outstanding work on this project, and all of our co-authors. And then Dr. Polimanti, if you want to mention the funding sources and things as well. So the National Institutes of Health funding for Dr. Polimanti's research efforts. With that,
National Institutes of Health. Oh, I was simply like acknowledging the support from the National Institutes of Health. Please go ahead.
Yes, I think that was all from my standpoint. Perhaps we can take any questions or comments. Thank you all for your attention. Yeah, this is a great question. So the All of Us research program and the biobank, the question is about how those with disabilities can interact with those. So in a nutshell, these are, as you said, these are research oriented data repositories, and in general, there's permission requirements, access agreements to gain access to that data. It's all anonymized, so even once you have access, you can't see any individual information that could identify participants. But it may be a little more difficult to access for the broader public beyond the research community. Now, with that said, there have been so many great studies from the UK Biobank and all of us that have been published now. I think that's a great jumping off point for individuals to understand questions they may have that maybe researchers have already explored, and they can understand the conclusions that have come out of those studies. And Dr. Polimanti is also providing the link there, for example, to the All of Us initiative.
Yes, so like unfortunately, the UK Biobank is not that I'm aware of. Is not recruiting any new participants at this time. They are following up participants that were already enrolled. Instead, the All of Us research program in the US for people based in the US is still recruiting. So if people, and they are very interested to have a representation of people with different conditions. And so if people are interested, I put the link in the chat, and you can click on join if you're interested to have more information. And I believe that people will be able to enroll in the study and ask more questions about the process, how they contribute to advance research in an area that they are particularly interested in.
Yes, absolutely. The UK Biobank was from some time ago. The All of Us is really ongoing, and so I think that, at least for those in the United States, we should emphasize that is an opportunity to contribute and to learn more. And then this is a great question about the self-reported pain data and also the predominantly European ancestries and the need for really expanding our studies to other ancestries. So starting with the pain being self-reported, this is a challenge with really all pain research, because pain is an important symptom, but a very nuanced one that everyone experiences very differently. And so we have a lot of standardized questionnaires that we use, but really that, I think, is a challenge just of pain research in general, that we're using things we've come up with as frameworks to understand, but the actual experience of pain is highly, highly individualized. So I think that's very much a work in progress across the whole pain field, and we should really be mindful of that, as you've stated, to not overgeneralize our findings or make assumptions. And then as far as the different ancestries, I think this is a great point. This is limited a bit by the nature of the populations that are enrolled in these studies and that are in each country. But really what this does is what this study does is it at least narrows down the list of possibilities, so that when we hopefully do these sort of studies using institutional data, that we can go a little deeper and better represent other populations, we have a hypothesis, sort of like a compass that we're starting with. And that can help take those small sample sizes and maybe make the work a little bit less of guesswork, and also allow us statistically to make a little bit stronger conclusions, because we're not doing as open-ended of a study. But this is definitely, I think, the next frontier that is important to explore. This is a great question about pain and mental health arising from similar locations in the brain. And I think, yeah, it is worth challenging any approach to this problem. That can we look at both of these at once? Should we look at them differently? And I think part of the reason that we do have to at least consider them separately is because clinically we diagnose and treat these conditions a little bit differently. There's obviously some overlap, but um, that's, I think, one important thing. And even though it's a little bit of a social construct as to what we're calling pain and what we're calling a mental health condition, um, that is still important to have an idea what we're treating, um, and how we can do it most effectively. The other is that as we're learning, really through network analyses in neuroscience, is that there are really an increasing number of locations in the brain, many of which influence more than one thing, but it's really more than just a single location problem. It's a network problem, and the way that each different node in that network is behaving is sort of the fingerprint for any condition or combination of conditions. So I think we're all looking forward to this next generation of neuroscience, neuroimaging, and blending that with our clinical findings to better personalize care. And I think, especially now with AI helping us to better analyze this data, approaching that will be the next big challenge. And yes, definitely, I think this nuanced relationship between, for example, depression and MS is a great point. Um, Depression also coexists with a number of other conditions, chronic pain, as we've talked about, but really so many different conditions head to toe across different organ systems.